let's begin our session. Good evening, everyone. Good afternoon, Raul, and good afternoon, Hasmik. Welcome to the APASL Hepatology webinar. I'm Yimin Mao from Shanghai, and I'm glad to moderate this session. The topic today is about drug-induced liver injury, which is a very challenging liver disease in the clinical practice. As we all know, there are more than 1,000 drugs have been reported to cause DILI. In the West, antibiotics are the most common drugs causing DILI. However, in the East, according to the data from China, from Korea, and Singapore, the herbal medicine is the major concern. Making the diagnosis of DILI is always very challenging because there's no diagnostic biomarkers, excluding the other etiologies of liver injury is the main strategy in the clinical practice. Leucam scale is recommended by the guidelines for causality assessment, but it still has some limitations, especially in the setting of clinical trial and the patients with pre-existing liver disease. So in this session, there will be one presentation and following a panel discussion. I think Professor Hasmik and Professor Tawasek will join the panel discussion. Today, we are very honored to invite my good friend, Professor Raul, as a speaker. Professor Raul is a very famous expert in the field of drug-induced liver injury worldwide. He's now the head of the Department of Medicine, School of Medicine, University of Malaga in Spain. He's also the founder and the director of the Spanish DILI Registry Network, which is the earliest DILI registry network worldwide with the history of more than 20 years. He's also the director of the Spanish and the Spanish Latin American DILI Network and the chairman of Prospective European DILI Network. Now, welcome to Raul. Raul.
Thank you very much. Good evening, everyone. First of all, I would like to thank the APASL Governing Board for inviting me to this hepatology webinar series, and also thank you very much, Jimmy Mao. Thank you very much, Professor Mao, for your kind introduction. Title of my topic, as Professor Mao commented, is drug-induced liver injury. These are my disclosure. Drug-induced liver injury has been for many years had been classified mechanistically in intrinsic, direct types, or idiosyncratic, a type unpredictable of liver damage. But very recently, a third type came along, which is called indirect type of liver damage in DILI. This type of DILI was proposed recently by Jacob Nagel and Einar Björnsson in a review in New England Journal of Medicine. And this type is characterized by drugs that are able to exacerbate persistent liver disease or alter the immune system because of their mechanism of action. For example, rituximab activating viral hepatitis B, chronic viral hepatitis B. And the incidence of DILI is really not well known. you can see in the right part of the slide that in China, it has been reported to be more than 33 cases per 100,000 inhabitants per year. In Europe, a calculated average incidence almost is roughly 10 cases per 100,000 inhabitants per year, and the lowest incidence had been reported in a population-based study in US. In Delaware, 2.7 cases per 100,000 inhabitants per year. Probably because the design of this study are quite different, retrospective, prospective, population-based study, and the criteria for defining DILI are also quite different. For example, the more stringent criteria coming from the US study. But as you can see in the right part of the slide, in the important study published from China last year, is a retrospective 3 years study from the Jimmy Mao group. You can see that over these 3 years, increasing incidence of DILI was reported. So the incidence of DILI seems to be increasing in the world. What are the drug classes more frequently involved in DILI? As Jimmy Mao commented before, anti-infectives, particularly antibiotics, are topping the list of drugs responsible for DILI across several prospective DILI registries, as you can see in this slide. Followed in some of them by herbal and dietary supplement that, for example, in the Latin America DILI registry occupied the 3rd position. But if you look at in the East, as commented before by Jimmy Mao, either in Korea or in China, herbal and dietary supplements in Korea represented more than 50% of the cases reported, and traditional Chinese medicine or herbal and dietary supplement topped the list of causative agents in this important retrospective study from China. The NIH, the National Institute of Health, were able to build up a free access webpage in which there is updated information of several agents capable of induced hepatotoxicity. This, you put the name of the agent, the suspected agent in this screen in the web page, and you get updated information on the potential hepatotoxicity of the drugs. More than 600 agents, including also herbal and dietary supplements, are listed in this web page. So this is an important resource for information on hepatotoxicity. What about the pathogenesis of drug-induced liver injury, of idiosyncratic drug-induced liver injury? The pathogenesis is complex and not well known, but there is a general agreement that the production of reactive metabolites is an important first step in many cases. And these reactive metabolites can produce liver damage that after that stimulate the immune system, or directly the reactive metabolites probably also are able to elicit an immune response. And you can see that this process starts in many instances, but only a subset of patients will progress to severe liver injury or even acute liver failure. And this is because there are very effective mechanisms of adaptation that prevent further damage, and the damage subsides in many cases. The role of microbiote is just emerging. We have very few data humans, but is probably to be very important in many cases. During the last year also, GWAS studies had identified several HLA class 1 or class 2 alleles and haplotypes that are associated with the risk of hepatotoxicity with several drugs. Sometimes drugs that are very different in mechanism of action or in chemical structure are sharing the same allele or haplotype, such as, for example, the case of amoxicillin clavulanate lumiracoxib or the HLA class 1 A3301 for terbinafine, ticlopidine, or fenofibrate. And also, an HLA class 1 allele has been recently associated with the risk of hepatotoxicity with Polygonum multiflorum or green tea. When in a more recent study, conditioning by removing all cases of amoxicillin clavulanate that induce signals in chromosome 6 in HLA region, an international collaborative group of investigators were able to identify also a new polymorphism in chromosome 1, which is a polymorphism in the gene protein tyrosine phosphatase non-receptor type 22, which is codified by a protein, and this polymorphism has been also been involved in autoimmune disorder. So this is a new general risk factor, genetic general risk factor for hepatotoxicity, regardless the group of drugs. And putting together these findings, you can see that for subjects that are carriers of the RIX allele, the adaptive immune response to the insult, to the liver insult, is characterized by the production and presentation of reactive metabolites to CD8 positive lymphocyte through the antigen binding site of HLA class 1 molecules. And you can see that there is also a new addition to these risk factors, genetic risk factor, polymorphism in this gene, ERAP2, with codified for peptidase that are the function to trim peptides so that they fit into the antigen binding site of HLA class 1 molecules for a better presentation to lymphocyte. So this new polymorphism has been identified specifically for a large series of amoxicillin clavulanate cases. But many subjects that have these carrier alleles will not progress because they have very effective adaptive mechanisms that prevent further damage, as I commented before. But for some of them, to be carriers of several of these alleles sum up in order to increase up to, in the case of amoxicillin clavulanate, up to 18.5 folds higher risk of hepatotoxicity than subjects who are not carriers of these alleles. And very recently also, an international collaboration has proposed a polygenicity in a dish strategy to assess the risk. And this paper proposed the development of a polygenic risk score by aggregating the effects of several genome-wide losses associated with DILI risk previously identified by an international drug-induced liver injury consortia drug-induced liver injury network collaboration. The utility of this new polygenic risk score was validated using GWAS data obtained from an independent clinical trial of a hepatotoxic drug, as well as multiple donor derived organoids and primary hepatocytes treated with a variety of hepatotoxic medications such as cyclosporin A. This approach suggests, and this was specifically predictive for the cholestatic mixed type of liver damage, not for the hepatocellular one. But this approach suggests that in silico toxicity modeling coupled with in vitro genomic and transcriptomic approaches might identify compounds with potential for DILI before entering clinical trials. We have to see, but this is a very promising new data. What about the presentation of DILI? The phenotypes of DILI are very varied. And you can see in this slide that several acute or chronic phenotypes can be the expression of DILI. And these phenotypes are associated with several types of drugs that sometimes some of these drugs are sharing different phenotypes, but in general, the most common phenotype is that of acute hepatitis resembling viral hepatitis. But many other phenotypes are possible with different clinical manifestations, different biochemical abnormalities, and different clinical outcomes. And, but for practical purpose, what we do in clinical practice and also in prospective DILI registries is to classify the phenotype of DILI according to biochemical criteria. And you can see that these are data from several registries, and you can see that the pathocellular type in blue is the most common phenotype of DILI across the registry, followed by the cholestatic in red and the mixed type of damage in green. And but we very recently we have finished an analysis of our registry. The data are already online in clinical pharmacology and therapeutics, and you can see that in this analysis, when classifying the patient according to group of age, you can see that the older the patient, the higher the risk of developing the phenotype, the cholestatic phenotype of DILI. And this, interestingly, this was regardless in this group. For example, you can see red, in red is the cholestatic phenotype, accounted for 50% of all cases in this very old group of DILI patients, older than 85 years. And you can see that this was adjusted by the number of comorbidities and the number of co-medication. So this is a net effect of the age in the phenotypical expression of DILI. And very interestingly, when we compare the phenotypes in patient for a specific drug, for example, amoxicillin clavulanate, or the top drugs responsible for DILI in our registry, amoxicillin clavulanate, atorvastatin, levofloxacin, ibuprofen, you can see that depending on the age, the phenotypic expression is different. So the older the age, the significantly higher the probability of developing a cholestatic phenotype. So age is clearly a host factor accounting for the phenotypic expression of DILI. What about the diagnosis? The diagnosis of DILI, as Jimin Mao mentioned before, is very challenging. With this is due to the fact that it's a rare condition. The phenotypes are very variable, as commented before, But the most important reason is the absence right now of diagnostic biomarker for DILI. So very recently, in the ESL Clinical Practice Guidelines launched by the European Association for the Study of the Liver and published in Journal of Hepatology last year, we proposed a stepwise approach to DILI diagnosis in this algorithm, in which DILI suspicion, when facing any abnormal biochemistry or acute hepatitis, is the most important initial step, followed by a careful inquiry on exposure to herbal dietary supplement drugs, over-the-counter or prescription drug, and very importantly, recording start and stop dates. This is a very important point. Record the initiation and the stopping of therapy. And after that, it's important to calculate the biochemical pattern of liver damage to better tailor the diagnosis approach using imaging techniques or serology, specific serology. And also we need to consider liver biopsy in some specific circumstances. For example, when there is a negative or incomplete challenge, to better define acute or chronic atypical presentation, for example, vascular syndrome such as sinusoidal vascular syndrome, or always that there is a phenotype of autoimmune hepatitis. Recently, also, a set of investigational biomarkers had been proposed, had been identified, proposed, and validated. These are biomarkers that are called mechanistic biomarker because they are able to inform about the presence of necrosis, hepatic stress, apoptosis, or mitochondrial dysfunction, but and also for immune activation and risk of progression in some of them. But the performance in terms of specificity of this biomarker as compared with traditional biomarkers, for example, ALT or AST, have been really disappointed with no really an improvement of the specificity of these traditional biomarkers in identifying DILI. But in this paper, published also last year, you can see that the use of some of these biomarkers in combination with classical score for DILI prognosis, such as MEL, can help in clarifying the risk of patient in the green zone. You can see that MEL was very effective in predicting a worse prognosis when equal and higher than 30 points, and benign prognosis when lower than 20 points. But for the green zone, the addition of these two biomarkers, full keratin 18, above a given threshold, and macrophage colony stimulating factor receptor 1 above another given threshold, can identify more specifically the group of patients that finally will progress to acute liver failure. And some comments about Hy's law. Hy's law is a concept developed more than 50 years ago by Hyman Zimmerman, observing that patients with the hepatocellular type of damage and high bilirubin at presentation have a chance of mortality not lower than 10%. This was formerly defined as an ALT above 3 plus total bilirubin above 2 folds, and used recently by the FDA with a modification instead of ALT above 3, using the R ratio, which is the result of dividing ALT upper limit of normal by ALP in upper limit normal, also with a value of equal or above 5. And this has been successfully used by the FDA in clinical trials of drug development in order to predict severe liver damage once the drug is marketed. If there is 1 or 2 cases of high-slow cases in a clinical trial, probably the clinical trial should be definitively stopped. But also for clinical practice, we have used this high-slow in our registry for prediction of progression at the presentation, and we have refined the high-slow by proposing a new R, which use AST or ALT, whichever higher, in this ratio. And this is because we observed that AST was highly predictive of the risk of fulminant liver failure at presentation, of DILI presentation. So when we look at the performance of this new high-slow, you can see that this has a better balance between sensitivity and specificity, with a higher area under the curve. So this has been independently validated by the DILI group in a later paper. So it's probably a better score for predicting acute liver failure in clinical practice, but probably also in drug development. And beyond high-slow, there are other factors that can account for greater mortality. This is the result of a study from the Indiana group with patients included from this place, from this site in the DILI cohort. You can see the cohort coming from Indiana was, this was the discovery cohort, was evaluated, and the authors were able to identify that the Charlson score, important comorbidity, Charlson score above 2, was associated with a lower 6-month survival after DILI presentation. And this was the discovery cohort and was independently validated by the North Carolina cohort, also belonging to the DILI group. And you can see that in addition to the Charlson score, other independent factors associated with this lower survival in the logistic regression analysis were MELT and albumin. And using these 3 scores, these 3 parameters, they were able to build up a calculator in order to predict the 6-month mortality, the risk of 6-month mortality of patients presenting with DILI. And in our analysis, in this analysis, I commented before, recently published in Clinical Pharmacology and Therapeutic, you can see that patients older than 85 years had more severity at DILI. So age was also associated with more severe DILI, more severe and more moderate DILI than the other age groups. And in our cohort, we were able also to validate these parameters, parameters that are associated with the risk of mortality. For the overall mortality, MEL score, the comorbidity burden, but not the albumin, and for the liver-related death, liver transplantation, the full parameters as identified by the Indiana group were also associated with the risk of liver-related death or transplant in our analysis. What about therapy? There is not yet a specific therapy for DILI. The most important action is to stop any non-essential drug in order to prevent further damage and the standard criteria for referral to a liver transplant center also applied in the case of idiosyncratic drug-induced related acute liver failure. But there is a clear lack of absence of evidence-based therapies. Recent clinical trials conducted by the Jimmy Mao group evaluated the role of magnesium isoglycinate, but this was a non-placebo control trial using troponin as a comparative drug. They include patients with mild or moderate liver damage, and in this group they observe a fast resolution of liver tests using this drug. So this is a promising result, but this further validation. Also, NAC is being used in a placebo control trial and show to improve transplant-free survival if this was used in early stages of encephalopathy. Also, steroid or use of oxycholic acid has been used anecdotally in non-controlled studies according to several different indications. For example, also Mars had been used anecdotally in DILI to improve outcome. We have recently analyzed the use of corticosteroids, use of the oxycholic acid or Mars in our registry, but this was the use decided by the physician at charge, the physician that submit the case to our registry, individually decide to use or not these therapeutic approaches. You can see 66 patients were treated with corticosteroid, 50 with ursodeoxycholic acid, and only 12 with Mars. These are still unpublished data. You can see that the patient treated with some of these alternatives had more jaundice, were more frequently jaundice, were more frequently hospitalized, had more percentage of hypersensitivity features, and they have also higher levels of total bilirubin and alkaline phosphatase, and because they were more, they have more serious DILI, they were in a worse condition, they have also a higher frequency of liver-related death and liver transplantation than patients who did not receive therapy. So this is my last slide, and I would like to conclude my presentation with some take-home messages. Liver injury induced by drugs or complementary and alternative medicines is a growing health issue worldwide. Genetic association indicate the important role of the immune system in DILI initiation. The phenotype of DILI is very variable and is influenced by age and probably by other factors, but clearly by age. The diagnosis of DILI still relies on exclusion of alternative causes, and investigation and new biomarkers are being rather informative of liver injury mechanism or prognosis than specific for DILI. The highest low can be refined for an improved balance between the sensitivity and specificity. And DILI therapy is mainly supportive, but we need clearly properly design and power clinical trials of potentially effective drugs. So finally, I would like to thank all my group, all the collaborators of the Spanish, Latin American, and European DILI registry, and the international collaborators as well. Thank you very much for your attention.
Okay, thank you, Professor Raul, for your excellent presentation. Now I think we may move to the panel discussion part. There are some 3 questions I see. First is about what about the association between the BMI and the DILI?
BMI and DILI.
BMI.
Yes. Obesity. You mean obesity?
Yes, obesity.
Obesity and DILI. There is no consistent data. There is no consistent data for the general risk of DILI. There are data for specific drugs, for example, for halothane, all data. These are all data. This anesthetic, but not for the general risk of DILI when exposed to different drugs. Sometimes, if BMA is associated with NAFLD, of course, the risk of worsening NAFLD is clear with some drugs, for example, tamoxifen. This is very well known, and for other drugs, antipsychotics, new antipsychotics that are drugs that induce weight gain. So, but it's not really a risk for a general risk for DILI.
Yes, thank you. And Professor Hasmik and Professor Tawasak, any questions about Raul's topic about DILI?
Maybe I should make a comment, Professor Mao.
Yeah, George.
Yes. This is an excellent discussion, and the presentation is really well done. But you can see from the figures in China, DILI is more prevalent, more frequent than any part of the world. But taking into the heterogeneous natures of the complexity of making a diagnosis, I just wonder whether there is any standardizations in how you can exclude all the other possibilities without the liver biopsies and so on. And do you have long-term follow-up studies on all these DILI patients after the eliminations of these potential etiologies to really clarify this is a DILI-related hepatotoxicity?
Yes, thank you very much. It's a very interesting question. There is no standardization aside from the you mean the approach to the diagnosis using a standard test for diagnosing liver injury. There is no, aside from to focus further on serology, for example, in hepatocellular or mixed cases, serology to exclude viral hepatitis or alcoholic hepatitis or autoimmune hepatitis, and for the cholestatic type, the need to judicially use imaging techniques in order to exclude biliary obstruction. There is no another specific approach. And for the long-term follow-up, I think it's very interesting, this question, because you are right. Sometimes if you don't have baseline tests of the patient before DILI initiation, it's difficult to ascertain if the patient, when DILI improve and DILI tend to resolve, if the persistence of abnormalities is because of the persistence of liver damage, and so the patient has developed chronic DILI, or is the result of a persisting disorder. And this is particularly difficult for example, in patients who have risk factor for non-alcoholic fatty liver disease, which is a very common liver disorder right now. But we have performed carefully follow-up. Our results were published 4 years ago in Journal of Pathology, and we found that 8% of acute DILI may go into chronic DILI. I know that in the very large cohort in China, there is also data of chronicity, even with higher figures than figures that we found in our analysis. So chronic DILI is chronic non-resolving DILI is a reality. It exists, does exist, you know?
Yes, thank you. Thank you, Raul. Professor Tosca?
Thank you, Professor Andrade. There are so many questions. There are a question from a Japanese colleague asking that current use of molecular targeted drugs and immune checkpoint moderator for cancer treatment. How about the daily features of those who underwent this treatment? Is there some different characteristic?
Yes, well, this is an emerging area of DILI investigation. Really, I didn't address this topic because I think it needs more time and probably was out of the scope of this general presentation. But this really clearly this new class from the new classification of DILI is indirect type of DILI because it's the alteration of the immune system lead to an immune-mediated DILI, and the frequency of severe DILI is very variable across studies. There is a main problem here. There are no biomarkers for immune-mediated DILI, specific biomarkers. We need also an adjudication. Adjudication is very difficult in many cases because of you have to exclude the progression of the tumor with such as competing alternative and other, for example, infection, hepatitis, viral hepatitis. So this needs a very careful approach, adjudication process. And importantly, also, I think we need to refine our criteria for standardization of the immune-mediated damage, because of oncologists tend to start very early with corticosteroids, and this is an important barrier to clearly characterize the liver damage. So we think we need consensus criteria with oncologists in order to correctly manage this patient from a diagnostic and therapeutic standpoint.
And in the patient with critically ill and with sepsis and receiving so many drugs, and you have any advice or clue for them to, how to differentiate between the DILI and jaundice from the sepsis? And in case that there are so many drugs that are potentially toxic, do you have any clue on that?
No, this is a very difficult question.
Right.
Very difficult question. I have not the magic bulb for this difficult to answer question. It's really difficult because sepsis has a typical cholestatic pattern, but several drugs can induce the same pattern of DILI. So if the patient is receiving several different potentially hepatotoxic drugs, antibiotics, for example, different antibiotics at the same time, it's very difficult to know exactly what the agent is responsible for DILI. So this is because we need, for these difficult cases, very tricky cases, we need really adjudication committees. We need an expert panel in order to assess the case, and by voting to adjudicate for one drug or another, or for a combination, or for finally excluding DILI in these patients.
Yeah, I totally agree. And maybe the last question before we close, is there any roles of liver biopsy nowadays? Because we have so many markers to investigate.
Liver biopsy, as commented and is proposed in the APASL clinical practice guidelines, should be used only in specific circumstances. For example, if it's necessary for specific phenotypes, clinical pathological phenotype, for example. A typical example is sinusoidal obstruction syndrome, caused, for example, for oxaliplatin. You need a liver biopsy in order to establish that there is a sinusoidal obstructive syndrome. But for other, for example, for NAFLD or NASH associated with some specific drugs, you also will need a liver biopsy. But for the general of the cases, for the common of the cases, is not necessary. Also to exclude alternative causes, particularly when there is an incomplete rechallenge, and this is the case, for example, or cases evolving to chronicity. You will need probably a biopsy in order to make sure that there is no alternative cause causing the liver injury, and also to characterize the intensity of the damage according to the biopsy. And always a biopsy is necessary when what you think is presented with an autoimmune phenotype, because you will need the histology when you decide finally that the case is not DILI and is classical idiopathic autoimmune hepatitis. You will also need the biopsy to characterize this diagnosis. So these are in general the indications.
Thank you very much. I pass my role to Professor Mao.
Yeah, thank you. And there's a question about, do you believe some of the cholestatic injury might lead to PBC, like picture in the long term?
I couldn't understand the question. What is the question?
Some cholestatic injury. Do you believe some cholestatic injury might lead to PBC, like the picture in the long term? In the long term follow-up, some cases will turn to the PBC.
You mean ductal injury in the bile ducts?
Cholestatic injury. Cholestatic injury.
Caustic. You mean caustic injury?
Yes.
No, I don't. Yes, I know that there is published cases, but I don't have personal experience on that. Some drugs, some chemotherapeutic drugs can induce this kind of damage occasionally, but I don't have a personal experience.
Yes, thank you. I think in the clinical practice, sometimes the drug may act as a trigger. For some cases, they will become to the autoimmune disease.
Yes.
Maybe some cases will turn to the PBC or AIH, drug-induced autoimmune hepatitis. So thank you, Raul. And
Fully
I
agree,
think,
fully agree.
yeah. Another question is about the treatment. You know, in the European guideline, you mentioned 4 drugs, and however, in the East, especially in China, there are a lot of liver protector agents. So, but most of them are lack of evidence. So, what's your opinion to this kind of research, interventional research, about the protocol design, how to design interventional research, and what's the primary endpoint is the best one? Do you have any comments on that?
Yes, yes, it's a very difficult, also a very difficult to answer question, because the reason, in my opinion, the reason why we do not have evidence is because it's very difficult to design clinical trials, power clinical trials with enough number of patients to get a statistically power conclusion, and with a strict definition of DILI. So maybe DILI is very heterogeneous in presentation. So you need probably to have the more homogeneous cases as you can. So patient with hepatocellular pattern, compare with, for a strict comparison. In other trials, you may include only cholestatic mixed cases. This may be a reason, because otherwise it's very difficult to analyze the impact of, for example, if a patient had predominantly cholestatic pattern, the endpoint of measuring ALT is not clearly effective, it's not enough effective or appropriate to measure the potential improvement. So we need homogeneous patient with homogeneous phenotype and homogeneous severity. But in general, I think in the meantime, until we have really new drugs very well developed, very well investigated in clinical trials, I think the use of many of the drugs that are used in China that are antioxidants and they are very safe in profile, I think is maybe a reasonable approach, particularly in cases with mild DILI. Of course, in cases with severe DILI, may work or may not work, but there is no other alternative either. So you can use antioxidant drugs in patients, and this is, in my opinion, particularly justified, for example, when using chemotherapy for cancer or anti-tuberculosis regimen. So because you have, you know that you are going to have at least a fraction of cases with elevation of ALT that may or may not progress. So in this situation, the use of antioxidant may be justified, but we have to we had to realize that we had no evidence yet. So this is the point, I think.
Yeah, thank you, Raul. There are 5 minutes left. I think the last question is about, there are some, maybe there in the clinical practice, some patients may take several drugs, but the DILI happen. But how can we identify which drug is the cause of this DILI?
It's the $1,000,000 question. No, it's very difficult. We have right now, we don't have tools so far to differentiate one. We have to guide for the phenotype induced by one drug against another. The typical phenotype, for example, if you are using, for example, amoxicillin clavulanate with an non-steroidal anti-inflammatory drugs that is associated typically to hepatocellular damage. If the damage is hepatocellular, the probability of to be the non-steroidal anti-inflammatory drugs will be higher, but you don't have any specific tools. You know that we have working with National Center for Toxicology Research, Min-Yun Chen, you know this guy, Min-Yun Chen from the FDA, analyzing, you know, the drug properties according to the presentation of the phenotype. So when this analysis will finish, I think we have more knowledge and more probably the probability to develop a score in order to assign to one drug or another the you know, the responsibility of a specific DILI.
Okay, and the last question: can we use the Lucam scale to score separately for these 3 or 2 drugs? Which
yes,
one is the high score? Which way?
Actually, we should do it. We should use the Lucam, and sometimes the Lucam score is the you know, the tool that help us to decide if it's a drug or it's another drug, depending on the final score. But you know, it's in some way this is a blind approach, because you know, I think it's more important is the, you know, the clinical judgment, you know, the clinical judgment and the clinical experience than the you know, the final score that Lucam give us. So you should use when you have more than one drug, but I don't think that the score is the final score for one drug being higher is the, you know, the last word for this case. I don't think that.
Yes, I agree with you. So I think the time is up. So we have to close this session. And finally, I would like to thank Professor Raul for your excellent presentation and for your excellent the discussion. And also, I would thank to the Professor George Tawaska and Hasmik and the other professors join this panel discussion. Thank you again. Thank you.
Thank you. Thank you.
It's excellent. Thank you very much, both of you. Thank you very much.